goals of macular surgery, as all of us are aware, it's a good anatomical closure with a good functional outcome, and to reduce the toxic damage because of the various dyes used, and reduce the phototoxicity. This is one of the surgeries where the light pipe is held very close to the retina, and of course we are operating in a very vital, sensitive area, so surgical skills is very important. So I will be talking broadly on preoperative, perioperative and postoperative tips. And patient selection, the confounding factors in yesteryear has been the size of the hole, the duration of the hole and the presenting visual acuity. And this definitely has an impact on the functional outcome. And the patient's comorbid condition, in case if the patient is not able to maintain the positioning, because positioning is as important as the surgery. So preoperative lens status is very important, because most of the time we combine the macular surgeries along with the cataract surgery. So lens status assessment is important. And the other small tip over here is in a slit lamp biomicroscopy, look at the ILM wrinkling, because this could give you an idea about where to initiate the nick when you do an ILM peeling. And as I said, most of the time we combine with an phacoemulsification. All the patients above 50 years we combine it. And the advantage for combining is because there is a better visualization of the posterior pole, and as a one-step visual rehabilitation, there is a good red glow, so the VR surgeons can do a good phacoemulsification. And the important thing over here is you need to place the lens in the back, because when you put the patient in prone position, sometimes the lens can get subluxated or change the position. And what I do, because we put the patient in prone position, the inflammatory factors migrate anteriorly and may cause posterior syncope, which you don't like to have it. So I combine with 2 cycloplegics. And the other reason why I do combined surgery is because here we position the patient only for a week. And because of this constant rubbing of the gas on the anterior halide on the lens, the cataract progress is much faster compared to the retinal detachment surgeries. And IOL insertion, either you can insert the IOL in the beginning of the surgery or at the conclusion. I prefer to insert in the beginning of the surgery, because everything is done in the beginning. You don't need to come and manipulate the anterior segment at the conclusion. And the other thing is, if you are implanting at the end of the surgery, sometimes it's very difficult to visualize the posterior capsule. Sometimes you may end up eating up the capsule. And in an phakic or a vitrectomized eye, it's very difficult. In a vitrectomized eye, it's very difficult to insert an IOL because of the deep AC. So I prefer to insert the IOL in the beginning, but the only disadvantage is sometimes when you do the vitrectomy, you will have the peripheral optic edge coming into your view. But of course, in a macular hole surgery, it doesn't matter, because you're not going to do that aggressive base excision or a peripheral lesion to treat. And PVD induction is the first important step, and it's mandatory before you do an ILM peel. And here you can see the PVD induction. First you initiate from the disc. As all of us know, we just lift from the disc, go towards the equator and lift anteriorly. So now you can assess the amount of adhesions. If the adhesions are too strong, don't do this technique of lifting it from the disc, because you will create breaks in the periphery, and because the adhesions are stronger. In case the adhesions are stronger, what you do is lift, cut, because by this way the amount of force transmitted to the periphery is reduced. But if it comes off easily, then you can go with this technique. And as I said, if the PVD is very much adherent, it's enough if you induce the PVD up to the equator. And if you have not done good amount of PVD induction and a lot of peripheral vitreous is left, I would always prefer to put a peripheral bell buckle. And PVD induction up to lattice is more than suffice. No need to be aggressive anterior to the lattice, and lift and cut, as I told you. Sometimes if you are not able to visualize the vitreous, you can always use a triamcinolone assisted PVD induction. So the staining, the commonly used dyes were brilliant blue, tryphan blue, ICG, autologous blend and tricot, but nowadays I think 99 or even 100% I can say we are using brilliant blue. And the word chromovitrectomy was coined in VR surgery because of the macular hole surgeries, because here only we use the dyes in the. And brilliant blue is the most commonly used dye. And the advantage of brilliant blue is you don't need to do a fluid air exchange to put the dye, and because it's being an isotonic with a normal saline. And one more small tip over here is, because you are not doing a fluid air exchange, what I would do is when I inject the dye, I switch off the infusion and inject the dye, so that the dye goes and settles on the macula. And then once the dye settles on the macula, then I switch on the infusion, so that there is a positive pressure and the dye has better contact time over the macula. And then few drops may be more than sufficient, and you can see the instantaneous staining of the brilliant blue within seconds happening. and direct the tip away from the RPE to avoid the damage to the RPE. And in case you are very worried about the toxicity to the RPE, you can always put a drop of methylcellulose over the hole and then put the dye. And the other important thing is always misdirect the light pipe away from the fovea to reduce the photic damage. And with the brilliant blue, as I said, it's a non-toxic, easy to handle, greater affinity for ILM, no phototoxicity has been reported in vivo and does not require a fluid gas exchange. And ILM, coming to the ILM, is a very sensitive and very thin tissue of 2.5 microns in thickness, and in physiological condition the vitreous adheres to it, whereas in pathological condition it leads to PVR because of additions of the microblasts. And the current indications for ILM peeling is macular hole, epiretinal membranes, recalcitrant DME in vascular occlusions, and in post-RG surgeries to prevent future macular pucker. And why to peel? Yes, definitely all of us agree that the success of the macular hole surgery is definitely increased with peeling, and it increases the mobility and freshening of the hole margin, and it also decreases the diameter of the hole, and it promotes the glial plug formation. And visualization, either you can use Lander's lens or the wide angle viewing system. The wide angle viewing system is good enough in the present scenario. You have the magnific high mag lens. And only thing here is the depth perception is slightly reduced compared to the Landers, whereas the field is much better in wide angle viewing system compared to Landers. For the beginners, yes, you can first start your ILM peeling with Lander's lens because the depth perception is much better. And before we peel, ensure and coat the cornea again with viscoelastic so you have better view. And in case you have the epithelium is waterlogged, you can always scrape off the epithelium and select the lens of your choice. And most important is explain and tell your patient what you are going to do and why it is important for him to stand still or stay still. And when you start the peeling, look for the areas of ILM wrinkling after the injection of the dye. And you can cut across the wrinkles because it's easy to cut across the bridges rather than to cut in an area which is flushed with the surface. And in case of people are using the Bosch and Lomb system, you have the amber filters which helps you to visualize the ILM much better. And the instruments which you can use is, you can use an MER blade to create a nick. You can see there a small nick is being created, and then you are going and pinching, what we call this pinch and tin. The initial thing, if you are not using an MBR, you can use the forceps itself to pinch the retina. Along with the retina, you can pinch the ILM also, nothing will happen. And it's a gentle pinch. Once you make a pinch, you are creating a tent, and then the ILM is freeze, and then you can start rotating. And way to initiate, you should be comfortable, the patient, the surgeon should be comfortable with this wrist movements, and it should be always done in a direct visualization. What I mean direct visualization, you don't want the shadow of the instruments to obviate your view. If it's a right eye, I would suggest to initiate the nick from the infranasal or supratemporal quadrant because it's along the axis of your wrist movement. And if it's a left eye, the nick can be in supranasal or infratemporal. And always the nick is from outside to inside. And avoid the papilla macular bundle for the initial nick. And what we do is ILM, once you have made a nick, what is used is a grasp and regrasp. What I mean by grasp and regrasp is, so always hold the base of the flap and rotate clockwise. Again you go to the base. If you hold at the tip, the flap will fray. So you go to the base, and then you can use your instrument and then hold at the base and then rotate. And few superficial emerges will be seen. That's nothing pathological about it. And the other clue of peel is you will get an instant whitening within 10 seconds of your peel. And this is a schematic diagram where you can see the first nick is from outside to inside, and then hold with your forceps and start rotating just like you do your capsular excess. And once you made a small nick around the hole, you can enlarge to your convenience how much of a size you want. And ILM peel may be difficult, or it comes in piecemeal in certain scenarios. Like in a diabetic vitrectomy, if you can see there is a prolif over the disc. Sometimes it becomes very important to remove the prolif over the disc. Most of the time we leave it because of the worry of woos, but it's very important to remove this if there is a traction on the ILM. And in myopics, because of the schisis, the peel becomes difficult, and post-trauma or post-inflammatory or post-macular laser cases. And the other thing is, after once you have finished this peeling, see the second bottom one looks relatively a decent peel. There is enough whitening around the hole, but sorry. So this video shows enough of peel, but once you again put the dye, and then you can see the tags of ILM still adherent to the edges of the hole. So again, why I would suggest is to do a restaining after the peel so that you ensure that the ILM has been peeled well enough all around the hole. Another new technique which I started adopting for the past 2 years is an inverse flap technique. It's a very promising technique. So right now there is no currently contraindication for macular hole. Any macular hole, any duration, any size, except that the RP is healthy, can be closed with this technique. And the inverted ILM itself act like a substrate for the glial proliferation. That is one of the mechanisms proposed for the closure of the hole. So here are the one video about the invert peel. So here we make the ILM peels just like a flower petal. So just make multiple peels. You go to the base so that you will have a nice like a flower petal appearance. So go up to the edge of the macular hole. So like this you can go all around the hole. And then bunch up all this ILM just like gentle stuffing into the hole. And then you can cut the excess ILM with the help of your cutter. The only tip during using a cutter to remove the excessive tissue is sometimes your vacuum is so fast the entire ILM can go into your cutter. So I would suggest a low vacuum and a high cut rate like this so that the excessive tissues can be trimmed all around. And these are the few pictures of inverted peel, the color funders and the color funders and the OCT pictures. This shows a bunch up of tissue in the macular hole. The hole is closed. And this is a post-traumatic one. Again, the hole is closed, and the ERG, we did a multifocal ERG also showing some responses. And there's a few more examples of the inverse peel technique and few more OCTs. But initial time we were bunching up a lot of ILM into the hole, but later here we started cutting it off. And we have done around 15 cases, and touch wood, all the 15 cases have closed, and all the holes were more than 6 months or a year duration. And the ERM peel, fluid air exchange is mandated because you are going to use Trypan blue. And in a VMT, leave a tiny piece of tissue over the fovea because we don't want to create a macular hole because of surgery. And peripheral retinal evaluation is mandatory before you close to avoid unnecessary post-op complications. And fluid air exchange, when you do an inverted flap, I would always suggest you to misdirect or direct the port of your cutter away from the hole so that at the last piece of FGE, what happens because of the sudden pressure surge of vacuum, the ILM tissue also may come into your port. So you misdirect the cutter to the nasal quadrant. And tamponades, air is controversial. Short-acting SF6 I prefer for most of the holes. And why do we need position is isolate the vitreous fluid from contact of retina, approximate the edges, aids in glial closure. And probe position duration is controversial. What I do is 8 hours for a week, and because it takes time for the plug formation. And for residents, this is the simplest of VR surgeries to do, but the margin of error is measured in microns, so it has to be done only when your skills are fine-tuned. And phototoxicity, as I've already mentioned, misdirect the light pipe away from the macula most of the time. Use the Chandelier illumination as much as possible, and sometimes you can use dye under the air again to avoid phototoxicity. And OCT has really played a major role in understanding this pathology especially, and we can even gauge the duration of the hole with the OCT. If the OCT shows hole closure, yes, you can also tell the patient no need for further positioning. Thank you.